I'm Dr. Wazen, and I guess today's topic is dizziness, vertigo, and disequilibrium. I'm not going to show you any slides or pictures because there's really nothing to show that would make sense in this subject. But I'm going to go over with you all the differences between these type of symptoms, and I'm going to make this as an open forum, if you will, so I could answer as many of your questions as I can. So let's start by doing some definitions. Vertigo is the easiest one to define, believe it or not, because it is a sensation of movement. Typically, it's spinning. So you feel the world is spinning. Either you are spinning or the room around you is spinning. It doesn't matter what is spinning, as long as you get that feeling of spinning. It's not always spinning. Sometimes it's a swaying feeling or a sensation. Sometimes it's a falling sensation, but we call it like a hallucination, if you will, or an imagination of movement when there is no movement going on. So vertigo is very typical of inner ear disease. Inner ear disorders often present themselves with hearing loss or with vertigo. Dizziness is different. Dizziness could be described as lightheadedness or a feeling of almost fainting or a feeling of giddiness or funny in the head, anything that makes you feel that your balance or your head is not right, but it is not a spinning sensation. We're going to classify that as dizziness or giddiness or lightheadedness. The third category of balance disorders is disequilibrium. Disequilibrium means if you're sitting in a chair, you're fine. If you're lying down in bed, you're fine. But if you get up and start walking, you feel that your balance is off. You feel like you have to hold on to things, or you bump into people or door, and that's an equilibrium issue. So disequilibrium is something that happens on movement. Vertigo or lightheadedness can happen at any time, whether you're seated, whether you're lying down, or whether you're moving. So when we take the history, you come to the office, you say, I have some dizziness or vertigo or whatever you call it. Then we have to dig in a little bit further to determine, are we dealing with spinning attacks of vertigo, which leads us into investigating the inner ear more directly? Are we dealing with lightheadedness or dizziness, which opens up the whole field of beyond the inner ear? We're talking about circulation, we're talking about brain issues, we're talking about heart issues. It's a much wider selection of disorders that we have to investigate when it's a dizzy sensation. And with equilibrium or disequilibrium, that can happen with inner ear disorders, but also happens if you have neurological disorders, and if you have orthopedic kind of disorders, if you're having issues with joints and ankles and back and hips, all of that can contribute to equilibrium issues. So as you could tell just from these few moments, that when somebody comes in and says, I'm dizzy, we have a huge task in front of us to ask pertinent questions so we could narrow the field, so we could do our physical exam, so we could do the appropriate testing, so we could reach the final diagnosis. If we don't have a good, clean diagnosis, we're not going to have the appropriate treatment. So it's very important to put the diagnosis first, and then based on the diagnosis, we're going to talk about treatment options for that particular diagnosis. So let's now go into the different disorders that are most common with all of these different symptom complex. Starting with vertigo, one of the most frequent vertigo condition that we see or we suffer from is called benign paroxysmal positional vertigo. Benign is benign, nothing to worry about. Paroxysmal means it comes in spells, it comes in episodes. It could come, it could last for days, weeks, months, and it could go away by itself. And it could come back in the future. Positional means it happens when you put your head in a certain position. So benign positional vertigo typically happens when you lie down in bed, put your head down on the pillow, and mainly when you turn over either to the right or to the left, when you roll over in bed or you lie down flat, that's going to trigger this vertigo. It's a sensation of spinning. The room is spinning with you. You feel like the whole bed is spinning with you. It lasts typically less than 1 minute. Now, when you roll over again, it can happen again. But the actual episode is a short episode lasting less than a minute. It does not cause loss of hearing, and it does not cause tinnitus or any other ear symptoms. There's no pain, there's no fullness or pressure in the ear, there's nothing. It's just you lie down, the bed is spinning with you, it scares you, or you want to try to get out of bed to go to the bathroom, and it can hit you then. And sometimes it throws you back in bed. So, what do we do with benign positional vertigo? It's easy to diagnose because when you come to the office with these kind of complaints, we're going to put you on a stretcher. We're going to have you lie down with your head somewhat extended, turn to the right or turn to the left, and we're going to look in your eyes for something called nystagmus. Nystagmus is a rotatory movement of the eyeballs that is together with the sensation of vertigo. So you feel the vertigo, we see the nystagmus, we make our diagnosis. The most successful way to treat benign positional vertigo is with positioning maneuvers. And the most common maneuver is called the Epley maneuver. With this maneuver, what we try to do is to reposition the floating crystals in the inner ear system that have caused your situation. So the basic pathology in benign positional vertigo is we all have these little calcium carbonate crystals. It's like a microscopic powdered sugar that is stuck on a gelatinous layer like jello. And those crystals, we all have them, they shift because of their weight. When you move your head, move your positions, those crystals shift and create a nerve stimulation in the inner ear that goes to the brain, that tells your brain you're upright, you're tilted, the sense of gravity. All of that is based on the weight of these crystals on that gelatinous layer. In positional vertigo, these crystals are falling off that. They become floaters in the inner ear fluid and cause your symptoms. So the maneuver is to reposition these crystals where they belong. It takes 3 minutes. There's no pain in there. You lie down, we wait a minute, and then we rotate your head and your body in a certain arc to get those crystals to get back into that canal where they started. 3 minutes, you're done. 80% of the time, one maneuver like this is enough to eliminate the vertigo. Sometimes we have to do it again. After the maneuver is done, we place a small, soft neck brace so that you do not move your head up or down. And we ask you not to lie flat in bed. We want you up about 45 degrees. And we don't want you to reach up to get anything from a high shelf or bend over to get anything from the floor. All of that is just for 48 hours. After 48 hours, you can take off the neck brace and you could go back to your normal activities. As I said, 80% of the time, one maneuver is done, is enough. Sometimes when you return the following week, we check you again. If there is still some vertigo, we repeat the maneuver. So that's benign positional vertigo, and that's the Epley maneuver. Why is it important to make the right diagnosis? Because if you have vertigo and it's not from benign positional vertigo, you could do 100 Epleys and it's not going to help. So we see that all the time. We have vertigo, I did the maneuver, it's not working. Well, you probably do not have benign positional vertigo. So we have to look for the right diagnosis. Benign positional vertigo recurs. So the chances of it coming back sometime in the future is about 50%. So once you have it, you're likely to have it again. And it can happen a few months later, it could happen a few years later. I personally had it, and then I was free from it for years, and then it happened again. I just self-treated with the maneuver. Most people who try to self-treat, don't be frustrated with that if you are not successful. So if you try to self-treat, because people go on Google and they look to see what is the maneuver like, and they try to do the maneuver themselves. If it works, it works. Congratulations. If it doesn't work, just come on over and we will do it properly. There are very, very few cases of benign positional vertigo that do not go away. You do the maneuver again and again, and the vertigo does not go away. What do? There's a procedure, an operation we do on the inner ear to make it go away. It takes about an hour. It is a pretty safe procedure, outpatient, general anesthesia. We go behind the ear, we go through the mastoid bone to the inner ear system. We go to that canal where those crystals are floating. We make a little window in that canal, and we put a plug inside that canal to stop the flow of the fluid and the crystals. And that cures it. So the next condition that I want to talk about, that's also a common inner ear condition that causes vertigo, is called Meniere disease. Meniere disease, described in the 1860s by a French physician, Prosper Meniere. He described this collection of symptoms, which is an attack of vertigo, spinning vertigo. Now we're talking many minutes, hours, up to 24 hours. Spinning vertigo, nausea, vomiting, if severe, even diarrhea. The vertigo is quite disabling. So when you're having the vertigo, you cannot do anything. You just need to lie down, close your eyes, and wait for it to subside. We'll give you medications to help reduce it. It is recurrent. So it happens, it goes away. The following day, you're fine. It can happen again a month later, 6 months later. There is no rhyme or reason why Meniere's attack are coming. Other than the vertigo, so we have the vertigo, we have hearing loss with Meniere's. It's a low frequency hearing loss, meaning the low tones are the ones that are being affected first. The high tones are fine. It's the only condition of the inner ear that does that. Any other condition of the inner ear is going to give you a high frequency hearing loss, whether it's aging or trauma or ototoxic drugs or whatever else you could think of causes high frequency hearing loss. The low frequencies are fine. Meniere's is the opposite. You get low frequency hearing loss, the high frequencies are fine. And it fluctuates. So during the spell, the hearing goes down. The ear feels full, pressure, as if you have fluid in your ear. There is tinnitus, roaring, loud ringing in the ear. When the attack is over, the hearing returns back to normal, the tinnitus subsides, the vertigo is gone. And you're fine until the next episode. So, how aggressive we are in treating Meniere disease depends on the frequency of these symptoms. If you're getting an attack once a year, we will treat it differently than if you're getting an attack every week. What causes Meniere disease? Most of the time, we don't know. Most of the time, it comes out of the blue. But there are things that make it happen. Genetics, inner ear infections, trauma, physical trauma to the ear, or acoustic trauma, loud noise exposure. So these are things that can damage the inner ear system. So in the inner ear, there are fluid compartments. The inner ear, as you recall, is like a snail. Inside that snail, there are fluid compartments, and within those fluid compartments are the cells of balance and hearing. With Meniere disease, there is an increase in the pressure of that fluid or the volume of that fluid, which increases the pressure. So you have that increased in pressure. The ear feels full and blocked. And at some point, as the pressure increases, the membrane ruptures inside. And it is that rupture that is believed to cause that sudden decompression and the sudden vertigo attack. So the main way we want to treat Meniere disease is to decrease that fluid pressure and the fluid volume. And we use different kind of medications for that. We use a diuretic, which is a water pill, similar to people using in high blood pressure. There's a medication called Diamox or acetazolamide. This medication was used in glaucoma of the eye, which is a similar situation, except it's in the eye instead of in the ear. So that medication decreases the fluid production in the inner ear to decrease the frequency and the severity of the vertigo. We use antihistamines in patients who are allergic. We use steroids which are the most anti-inflammatory medications we have. We use something called meclizine to decrease the vertigo intensity. Sometimes Ativan or any of the cousins of the Valium family, diazepam, etc., are used to decrease that vertigo sensation. Once the episode is over, you're back to business. But when we are treating Meniere's, we are using those diuretics or those medications on a long-term basis, not only when the attack happens. The only thing we use when the attack happens is the meclizine or antivert, or the Valium or the Xanax or the lorazepam, etc. Those are used only during the attack. You don't want to be on them for long term. You have to be on a low salt diet. You have to be on low caffeine diet. And you have to be with no smoking and minimal alcohol. Stress is a major factor in Meniere disease. So we need stress management. Weather changes are factors in Meniere disease. You know, a rainy day, stormy day, the ear reacts to that, and you are more likely to get a Meniere attack. So if we change our dietary habits, and if we do stress management, and if we use the medications, 70 to 80% of people with Meniere disease will be fine. They go on with their life as usual. The others continue to have disabling spells, and those then we treat with procedures on the ear. And procedures are divided into minimally invasive procedures, and those are just injection of medicine in the ear, and regular surgical procedures. And the most effective and the most successful way to treat Meniere disease, eliminate the vertigo, and preserve the hearing is with a procedure called a vestibular neurectomy. The vestibular neurectomy is going behind the ear. We go through the mastoid. We go to the nerve that is conducting all of that information from the inner ear to the brain. And we're going to basically splice that nerve. That nerve has, it's like an electrical cord that has two divisions in it. So we separate that division and we transect the part that is doing the vertigo, leaving the hearing part intact. That is successful. I don't know what happened, but here we are. So we were talking about Meniere disease, how it's diagnosable, it's treatable. People think it is you have to live with it. It's not true. That's good for you to know. Now, how about talking about another type of disorder which causes you equilibrium issues? And it is part of the inner ear, and it's called an acoustic neuroma. An acoustic neuroma is a benign tumor of the balance nerve. And it starts as being a tiny little trying to get myself here situated. A tumor, a millimeter, 2 millimeters, and it slowly grows to become large and causes brain compression and bigger issues. The symptoms of an acoustic neuroma are tinnitus, a ringing or buzzing sound in the ear, hearing loss in one ear, and equilibrium issues. You feel like your balance is not perfect. It's not what it used to be. What happens, unfortunately, is that people ignore this, and they not just the patients ignore this, sometimes even their physicians ignore this. You go to the physician, you say, my hearing is down, I'm ringing my ear. And they're like, yeah, what do you expect? You're getting old and that's what happens. Well, it's not what happens, because what happens if you're getting old and you're having loss of hearing, it is happening on both sides at the same time. Hearing loss from aging is bilateral, meaning the two ears. Hearing loss only in one ear or tinnitus only in one ear needs to be investigated for another cause. It's not aging. People don't age only on one side. So we do the appropriate examination, we do the appropriate testing, and if we are suspicious of a neuroma, we're going to get an MRI. We're going to see whether it is there or not. Not every neuroma needs to be treated. Some of them we can follow with annual MRIs. Some of them we can radiate, and some of them we remove. But the key to this acoustic neuroma is single-sided loss of hearing, tinnitus, and equilibrium issues. So anybody who has issues like this needs to be investigated for that. We need to rule that out. Years ago, before we knew about all of these things, and before scans and MRIs and so on, people used to die from that because the tumor would grow too much and would cause such brain compression that people will die from brain compression. Not now, not anymore. But believe it or not, we still see large acoustic neuromas because people do not recognize the symptoms early and they wait, and then it gets larger. And by the time they get their MRI, it's the size of a golf ball, or it's the size of even bigger than that. And there's no room for that inside your brain area. Now, we talked about other kind of conditions that could cause you to be dizzy or lightheaded. Let's talk about the cardiovascular system. Your brain and your inner ear needs oxygen, needs blood flow. As long as the blood is flowing properly to your brain, you're in good shape. What happens if you reduce that blood flow? If you reduce the blood flow to the brain, you're going to start feeling dizzy, lightheaded. You're going to feel like you're almost fainting. And if it persists, you will faint. You will pass out. Fainting is due to a reduced perfusion of the brain with blood and oxygen. What causes that? A drop in the blood pressure can cause that. An interruption of your heartbeat can cause that. So if you have an arrhythmia, an abnormal heart rate, abnormal heartbeat, now the blood is not reaching up. If you have issues with blockage of the arteries that are coming up through your neck up to the brain, those arteries now are not wide enough to provide circulation. And now you have poor circulation to the brain area, and you're going to get dizziness and pre-syncope, which means before fainting, or faint. If you're feeling faint, or if somebody near you at a restaurant, at church, is feeling faint, lie them down flat on the floor. Don't sit them up. The immediate reaction, people want to bring somebody up. Don't bring them up. You want them lying down because the flow of blood from the heart to the brain is the easiest when they are flat. So you want to reestablish that circulation. They could wake up, they could realize where they are, etc. Then you could sit them up slowly, but don't fight nature. If you're dropping the blood pressure and if you're dropping the circulation, lie them down, or you lie down. If we are suspicious that we're dealing with a cardiovascular event, we're going to get consultations from our cardiovascular colleagues, cardiologist, internist, etc., to test the system, establish cause, and treat. Sometimes people require a pacemaker. Sometimes people require medications to regulate the heartbeat and regulate the blood pressure. Neurological disorders can also cause dizziness, imbalance, loss of balance, and sometimes vertigo. Parkinson's disease will cause imbalance. Degenerative neurological conditions will cause imbalance. Ataxia is the really loss of equilibrium. You cannot walk straight. All of these are central nervous system deficits that can cause disequilibrium, imbalance. They rarely cause vertigo, but they will cause equilibrium issues and imbalance. So during our questioning and our history and our examination, if we feel that this is a central issue, central meaning brain related, and we're going to get the help of a neurologist to help us with the diagnosis. If we feel that this is a cardiovascular issue, we're going to get the help of the cardiologist or the cardiovascular people. So the history and the detailed history on what is happening with you during these episodes is important in how we separate these things and do the appropriate testing and lead you to the appropriate diagnosis and lead you to the appropriate treatment. So I know there was some disruption in our video here, but I would like to save some time to answer your questions, as I said in the beginning. So have, Christina, have they been putting any questions?
How to get an appointment with you is one. I will email that information out.
Anybody wants to to pose a question, either verbally unmute yourself and speak, or type it, and we could read it to the rest of you.
Doctor, I have a question. Your transmission went out when you were talking about surgical options for Meniere's disease. We didn't hear the end of that. That's one. And number two, I'd like your opinion on the surgical procedure for Meniere's called endolytic sac decompression.
Yes. Endolymphatic sac decompression is probably the most common procedure that has been done for Meniere disease. The endolymphatic system is that fluid system that we spoke about, and that's increased in the pressure in that system is causing the vertigo spells. So The theory behind endolymphatic sac decompression is to go behind the ear, and the sac is within a layer, beyond a layer of bone. It's in the dura, which is the covering of the brain, but it's covered by bone. So we remove that bone to allow that sac to basically expand. So it's a widely performed operation. It's safe. It is not as successful as we would like to see. So the success rate with endolymphatic sac decompression is somewhere between 60 to 70%. The success rate of the vestibular neurectomy, which I was talking about earlier before we got interrupted, is about 97%. So it's a more predictable outcome. And in that operation, we go behind the ear also, but we go to the nerve that is conducting sound and vertigo from ear to brain, and we transect the balance half of that nerve to stop the vertigo and preserve the hearing. In the non-invasive, we use drugs in the ear, like steroid injections or microwick with steroids, or we use gentamicin. Gentamicin is an antibiotic that is toxic to the cells of balance in the inner ear. When we inject that in the inner ear, it kills those cells and it stops the vertigo. The success rate of gentamicin is about 80%, with a higher risk of losing hearing because of the gentamicin toxicity. The more gentamicin we give, the more hearing we're going to lose. So in general, the most effective with elimination of vertigo, preservation of hearing is the vestibular neurectomy. The second less effective is the endolymphatic sac shunt. And in the non-invasive, we could start with intratympanic steroids to see whether that helps. And if that doesn't help, we do the intratympanic gentamicin.
Erica has a question.
Erica, you have a question?
Yes, hi, doctor. I was wondering if any of the conditions you've spoken about today, if they result in fatigue, and if any of them result in noise sensitivity or hyperacusis.
Yes, yes, and yes. Fatigue, you know, when you're having a major vertigo attack, it really takes the energy out of you. So when the attack is over, for instance, in Meniere disease, for the next 24 or 48 hours, you're exhausted. You feel fatigued. With benign positional vertigo, there's no fatigue because it's a very short-lived vertigo. And in general, the rest of your system is fine. But with Meniere's, there is fatigue. And anything that damages the inner ear system, whether, as I said earlier, it's trauma or infection or disease like Meniere disease, you will have tinnitus as a result of that. And you may have also hyperacusis, or with Meniere disease, we don't call it hyperacusis, we call it recruitment. It's a slightly different mechanism. But with Meniere, the recruitment means even though you have a loss of hearing, the hearing is down, it doesn't take much more sound than your threshold for the ear to say, whoa, this is too loud. So a normal ear has a very wide range of hearing. From I cannot hear it to this is too loud is a lot of decibels. Meniere's ear, it shrinks. So between I cannot hear it and it's too loud is much narrower range than a normal ear. And that's the sound sensitivity. Any other question?
Yes, doctor, I just wanted to know, once you get the vestibular nephrectomy surgery, are you cured of Meniere's disease, or you can have another episode after that?
Well, if you are within those 97% people who do well, you're done. You're not going to get any more vertigo. So you basically are cured from Meniere disease in that ear. Remember, you have the other ear. So when we see somebody who is having recurrent vertigo after a vestibular neurectomy, we become very concerned that the Meniere is happening on the opposite side.
So do people get the surgery for both ears? Can you do that, or that's not?
No,
Okay,
that is not advisable.
okay.
And so for the other ear, we become more conservative. Maybe we'll do the shunt or we do the intratympanic steroids, but we will not use gentamicin and we will not do neurectomy for the opposite ear.
Thank you.
You're welcome.
I just had one quick question.
Okay.
If I have benign proximal positional vertigo, and at my last PT, when he had me lying on my side and I got up, my vertigo became much, much worse. And I'm finding now that when I walk, I'm constantly dizzy. What does that mean? Is it going to go away? It's gotten a little bit better, but not much. And I'm taking meclizine. I've never had this experience before, and I've been having vertigo for decades.
One of the problems sometimes we see in the treatment of positional vertigo is that the vertigo in the classical positional vertigo, the crystals are in the posterior canal. There are 3 canals in the inner ear. The most common cause is the posterior canal, and the Epley maneuver and all the maneuvers that you read about are to mobilize the crystals from that posterior canal to its base. What sometimes happens is that, number one, the crystals were not in the posterior canal to begin with. They were in the horizontal or lateral or canal. Or as part of the procedure, those crystals, as they are being mobilized, they fall into the lateral canal instead of the posterior canal. And that causes what you're having.
I see.
So it's important in your case to determine, one, is it a posterior canal or a lateral canal positional vertigo? And if your crystals have shifted from one canal to the other, then there are other maneuvers that are done to get them back where they belong.
Okay. Okay, thank you. I appreciate your time.
You're welcome.
Doctor, if you've got lateral positional vertigo, which I just got a little bit ago, like a month ago, and it's kind of a bad case, can they do, I guess, multiple of these? Because I'm going to go tomorrow and get another one, and it's it's also lateral in the lateral canal.
So which maneuvers are they doing?
She did, I don't know, I kind of rolled around. Does that make sense? That one, I forget what they call it, but I completely went around on the table.
Yeah.
And then I've got to go again tomorrow.
Yeah.
And it worked great for 2 days, but now I can feel I'm more off.
Yeah.
So I think she said I'm going to need 2 or 3 of these things. So, and part of the question is, I'm 25 years immune-mediated cochlear hydrops, and it's bilateral due to allergy and mold sensitivity and yada yada. And I've been told that when you have an ear problem, the propensity to get this positional vertigo goes up as well. So
True.
what would you say to somebody like me?
Yes, it is true. People develop positional vertigo out of the blue, and that's very common. You don't have to have any other inner ear disorder. But if you have Meniere disease or hydrops or any other kind of inner ear disorder, it is likely that you can also develop positional vertigo with that. And it could be posterior, it could be lateral. And that barbecue maneuver
Yeah.
is one of those for the lateral canal. So she's doing the right maneuver for the lateral canal. If that doesn't work, there are other maneuvers that are also specifically for the lateral canal. And if she's up to date on all of that, she knows what to do.
Good. Yeah. Okay. All right. Thank you very much.
You're welcome.
Doctor, one more question. My doctor has been giving me steroid shots in my ear, and she said now she's going to put me on beta histine. So do you think that's the right way to go? Because she says she think I have Meniere's disease. So I've been getting the shots in both ears, and tomorrow I go for my third shot.
Did you say you have it in both ears?
She never really told me. She said she think it's the left ear.
I mean, we have ways to know where is it from. We don't leave it to, I think. So we need to determine where it's coming from. We need to determine that it is Meniere disease. And if it is, then the intratympanic steroids work, but they don't work on everyone. I think if your disease is steroid responsive, it'll respond to the steroids. If not, it will not. He could give you 10 and it won't work. So beta histine, I'm glad you asked. We use beta histine sometimes. It's widely used in Europe and everywhere else in the world. It is not formulary in the United States because some time ago, the FDA felt that beta histine failed to prove efficacy. And they said, this is a useless drug. Let's take it out of the market. But there are people who respond to it. There are people who believe in it. There are people, and we prescribe it when we're at a dead end and we did this and we did that. We're like, okay, well, let's try this beta histine, and people get it from compounding pharmacies because they could get it as powder, and the pharmacist could make pills out of that. But you could buy it from Canadian pharmacies, from Canada, from Mexico, from Europe, from anywhere in the world. It comes as a regular, medication. It's called SERC, SERC, or beta histine.
Okay, thank you.
You're welcome. So I hope I gave you some broad idea about when somebody walks in with dizziness, that it's not a simple, it's not like I have a, ear infection. You look, there's an infection, you give them eardrops and they're done, or antibiotics. This is more complex. It takes more time. It takes testing. It takes consultations, and the treatment is really customized to every patient. You don't have to live with it. You have to do everything you can to find the right diagnosis, find the right treatment. Eventually, we may end up saying we've reached, everything we could do today. And until you've done that, don't believe the you got to live with it story.